Good morning, good afternoon, or good evening, wherever this video may find you. Coming to you live from various places to talk to you today about pathophysiology of the esophagus and the stomach. So go ahead, put us on double speed, and let's get to it.
Thank you, Michael, for that great introduction. To start us off, we will be talking about esophageal varices. Okay, so I do have to warn you, some of these pictures are kind of gross and graphic, but without further ado, here they are. So esophageal varices are just enlarged veins in the esophagus that are super fragile, and they occur when blood flow to the liver is blocked through whatever kind of um, liver pathology. And then in this first one, this is a normal esophagus. And then the second picture, you start to see some of the bulging here. And then as we go, it gets worse and worse until you can't even see down the esophagus at all. So some clinical manifestations of EV include obviously difficulty swallowing if they become severe enough. They can even bleed, which is something that we'll talk about in depth later. And then hematotemesis, which is vomiting up blood, or melena, which is blood in the stool. And then patients can even experience tachycardia due to the excessive blood loss that they're experiencing when they start bleeding. And then these patients might also have jaundice due to its link with liver pathologies, and often bruise or bleed easily and can show signs of ascites, which is just fluid buildup in the abdomen. And then here in this picture on the left, we have very, very minor bleeding in some of the varices. And then here on the right is kind of an extreme example of just obviously blood gushing out of it. So some risk factors for developing EV are, like I said, liver pathology, so especially cirrhosis of the liver. If there's blood clot or high pressure in the portal vein, so again, just not adequate blood flow through the liver. And then there also is a parasitic infection. So thank you, Jim, for kind of engraving it in our head that if our patient travels, just be aware we might see some parasites. So just kind of be aware of that and be able to send to a doctor right away if you suspect that, or a physician right away. And then some risk factors for if the varices start bleeding, or for varices to bleed, is if they've had previous varices bleed, if they become large or start showing red spots or streaks, have a high HVPG, which is a hepatic venous pressure gradient, have severe cirrhosis, liver failure, or if they are continuing to use alcohol. Diagnosis of EV includes an endoscopy of the esophagus. You can do an abdominal CT scan or even an ultrasound over looking at the liver to detect scarring to see if you have any kind of portal vein hypertension. And then the treatment varies for if they're bleeding or not. If they are not bleeding, the primary aim is to prevent bleeding because that's when we really start to see problems. And we can do this with different medications, including beta blockers, or we can do esophageal variceal band ligation, which we can see in this picture here on the right. They kind of put a little band around them and create a little bubble and just go in and go ahead and kind of suck the blood out. If you do choose to go that route, you will have to see your physician every 2 to 4 weeks, and then until they're gone, and then follow up 3 months after, 6 months, and 12 months after, just to kind of confirm that everything's going the way that the physician wanted. But if the varices do start bleeding, this is a medical emergency, And some ways to treat this are a red blood cell transfusion, just due to the blood loss that the patient is experiencing. A stent to divert the blood flow away from the portal vein to hopefully slow down the blood flow out. And then that includes using medications to do the same thing. And then if this just kind of becomes unmanageable with medications or the ligation, a liver transplant is likely. But they are looking in doing some kind of spray adhesive powder in the future where you would just spray it on the varices and kind of act like a glue to kind of prevent them from bleeding. Or if they do start bleeding, to kind of bring it on a more manageable scale where they can be taken care of right away. And then the prognosis, if you have bleeding varices, there is a 20% mortality, but morbidity and mortality have both decreased since our recent medications, our new medications and stuff that have become available. And if you have had a bleeding varice in the past, there's a likely that you will have one again. And then mortality increases as you have more varices return or recur. And then for PT implications, we should avoid causing ruptures. So we can do that by educating our patients on proper lifting techniques and avoiding Valsalva, and just avoiding different activities that would cause any increased pressure in the intra-abdominal area. And then just be able to send them to their physician if you are aware of the condition they have and you see different personality signs, or if they do complain of vomiting up blood or having blood in their stool. And then they can even show like edema in the ankles. So just knowing that as a sign for having these varices. And then it's also important to educate the patient on importance of rest and good nutrition to keep their liver functioning well. As I've said before, like the liver pathologies just really feed into this condition. And if you can keep those on a manageable level, these shouldn't be a problem. All right, now we'll turn it to Delaney.
All right, so I'm going to be talking about GERD. So GERD stands for gastroesophageal reflux disease, and this is a backward flow of gastric contents into the esophagus from the stomach. This can occur from failure of anatomic and physiologic mechanisms that are supposed to protect the esophagus. So there are two types that can occur. The first one is non-erosive GERD, which can occur without visible damage to the esophagus. And the second one is erosive GERD, which can be caused from other complications or injuries, which can include Barrett esophagus, esophagitis, or strictures. So GERD is one of the most common disorders seen in the clinic. In the US alone, GERD is the most common disease and accounts for $15 to $20 billion a year. About 10 to 20% of adults will have this disorder, and there's an equal amount of men versus females that acquire the disease. Typically, older aged adults will have a higher incidence to develop the disorder, and about 2/3 of adults in the US will experience significant signs or symptoms within their lives. Some of the risk factors mainly fall into diet, so this can include chocolate, peppermint, fatty foods, or caffeine. Some other common risk factors include obesity, smoking, or having a hiatal hernia, which will be discussed later in the PowerPoint. There are 3 factors that help keep our esophagus healthy. The first factor is making sure the anatomic barriers between the stomach and esophagus are working. So the lower esophagogastric sphincter, or the LES, is the most important for this. The second is making sure the mechanisms to clear the esophagus of the stomach acid are working properly. And the third factor is to maintain stomach acidity and acid volume. An anatomic barrier that is commonly disrupted in GERD is the LES. So this is the second most cause for reflux. And most people with severe GERD will have a decreased pressure of the LES. So as you can see in the bottom right corner is a picture of that sphincter that's relaxed and has decreased pressure. Also, hiatal hernias will have an increase of susceptibility to reflux. The esophagus, when working properly, has saliva and alkaline secretions to help neutralize the acid. It has peristalsis and gravity, which helps move food down the esophagus and will also help move the acid out of the esophagus. Some other complications that can increase the acid exposure include medications, cigarette smoking, or esophageal dysmotility disorders. Having those can increase the acid exposure, which can cause more time in the esophagus, which can increase someone's likelihood to develop GERD. Some other complications associated with GERD include esophagitis, Barrett esophagus, adenocarcinoma, or strictures. So the first picture represents Barrett esophagus, which causes a precancerous change in cell types, and you can visibly see the different colors of cells within that picture. Esophagitis is the inflammation of the esophagus and can cause erosions and ulcers from the limited opening in the esophagus. And the last picture shows a stricture, which looks very similar to esophagitis, but strictures are caused from granulation tissue. So it kind of has similarity looking of the Barrett esophagus with the different types of cells in there. The primary symptom of GERD is heartburn, which can occur 30 to 60 minutes after a large meal. Patients will typically have worse symptoms at night as they're laying supine because the reflux can easily move up the esophagus. Other common signs and symptoms include chest pain, regurgitation, dysphagia, and early satiety. Children and infants can also be affected by GERD. It's just not as common. Children will have similar signs and symptoms as adults, but infants will present their signs as crying, fussing, or refusing to eat food. About 1/3 of individuals who have heartburn-related GERD will present with other signs and symptoms not related to the esophagus. There are 3 common extraesophageal manifestations, which are asthma, coughing, and laryngitis. Asthma is thought to occur from GERD from the macro aspirations of the reflux material going up and down the esophagus. Individuals with a cough may present with signs and symptoms not associated with GERD, which may make it difficult to diagnose. To diagnose GERD, it's mainly based on signs and symptoms presented in the patient. So this will be presented as heartburn occurring more than 2 times per week with underlying complication of reflux. Some diagnostic testing include research, history, endoscopy, esophageal pH monitoring, and EGD. Impedance pH monitoring is a gold standard for patients partially responding to PPIs or proton pump inhibitors. As for treatment, it usually is to just relieve a patient's symptoms and to heal esophagitis if present. Medications typically start with your non-prescription drug like an antacid or a Tums. The next step up would be an H2 blocker to block the histamine that induces the parietal cells to secrete acid. The next line of medications would be a PPI, which is the most effective therapy for acid suppression. Individuals who partially respond to PPIs, have continued reflux, or have symptomatic hiatal hernias may also do surgery, which the next slide, I'll show you a few of the common surgeries that could be present. So the first picture displays an upper gastrointestinal endoscopy. This procedure uses a lighted tube that travels down your throat to examine a patient's esophagus, stomach, and small intestine. So that's how we were able to take pictures of the different other complications shown on the other slides. The next image is showing an acid reflux surgery called the Nissen fundoplication. For this procedure, the surgeon will wrap the top part of the stomach around the esophagus to reinforce the LES, or that sphincter that usually is more relaxed. And then the final picture is a substitute for the LES called the Lynx. So this device is an expandable ring that uses magnets to help keep the stomach acid from escaping up and then allows food to enter the stomach. When symptoms are present, a patient should remain upright for 3 hours after a meal and avoid meals 2 to 3 hours before bedtime. Other lifestyle factors include avoiding aggravating foods and to stop smoking. The prognosis for GERD is generally good. However, many people will have this disease for most of their life. Because of this, individuals can accumulate asthma and vocal cord inflammation or even laryngitis. If symptoms progress and individuals have uncontrolled acid reflux, they will have an increased risk of developing esophageal cancer, which we'll be talking about next, and this has a poorer prognosis. As for most diseases, exercise is important to maintain for someone with GERD. You should avoid strenuous exercise because this can inhibit gastric and small intestinal emptying. Individuals may have trouble exercising because this can worsen their symptoms and increase the reflux coming up the esophagus. To help decrease symptoms, patients should avoid high-calorie or fatty food consumption immediately before exercise. During a session, ideal positions for a patient are heads up or sideline positions. These positions help minimize reflux by decreasing intra-abdominal pressure and prevent regurgitation and agitation. If you do need a patient to lie supine, you should educate them to not eat right before a session. You should also educate your patient to lie on their left side at night, as this will help decrease their acid flow into the esophagus. All right, that's all for me. Next up is esophageal cancer.
All right, so section 3 here is on esophageal cancer. So there are two main types of esophageal cancer. The first is squamous cell carcinoma. So this is a type of cancer that will develop in the middle of the esophagus, and it makes up 90% of all types of esophageal cancer cases worldwide. And then the other type is adenocarcinoma. This is typically located in the distal portion of the esophagus, and it makes up the majority of cases of esophageal cancer we get here in the US, so 80% total. And overall, it's the 6th leading cause of cancer-related deaths worldwide. And in terms of who has the higher risk factor, it is men over women. And it is worth noting too, in the West in recent years, there's been a decline in squamous cell carcinoma and a large increase in adenocarcinoma, which is part of where that 80% in the US comes from. But this type of cancer overall is relatively uncommon compared to more common types like lung cancer, breast cancer, prostate cancer, that sort of a thing. Only makes up 1% of all cancers in the US. So etiology and risk factors, I split them up here by both types. They're slightly different. So for squamous cell carcinoma, one of the main ones is alcohol and tobacco use. And then Blacks are more susceptible. Chemical exposure, vitamin deficiencies, and HIV positive patients are more susceptible as well. Etiology for adenocarcinoma, the big one here, it typically develops from Barrett esophagus. This is a complication of GERD that may have been talked about already. But with GERD, you can kind of see in the picture there. And typically what you'll see is that the lining of the esophagus normally is kind of a white color. But with Barrett esophagus, it's kind of a red and velvety type of texture. 5 to 15% of people with GERD will develop Barrett esophagus, and this dramatically increases their risk factors and chances of developing adenocarcinoma. And risk factors for this type, middle-aged white men specifically, we touched on Barrett esophagus and GERD, and then also tobacco use, so that's the same for both, and as well as increased age, poor diet, and obesity, some common things that you will see as risk factors for all types of cancer. And so with Barrett esophagus, since that is one of the key points here, so you'll see some metaplasia occurring is basically what happens. So we're not sure why this occurs, but the normal epithelial cells in this area are replaced with columnar cells, types of cells that you will typically see in the intestines. And so you've got a case of things not being where they're supposed to be. And as a result, you're more susceptible to this type of cancer. So something to be aware of for sure. In terms of clinical manifestations, like with other types of cancers, early stage tumors are typically asymptomatic. And once they have progressed to a more later stage, that's when the symptoms start popping up. So you can see some of the popular ones that you would commonly see: dysphagia, initially issues with solids, and then progressing to issues with swallowing liquids as well. Weight loss, 90% of people affected there. Again, going back to our red flag questions. And then you can see some other ones: cough, hoarseness, chest pain, anemia, and regurgitation. And that's common for both types. So prevention, diagnosis, and staging. Prevention, again, a lot of things that we would typically do for any type of cancer patient: reduce weight, reduce smoking and alcohol use, and then obesity, prevent obesity. And we touched on earlier GERD and Barrett esophagus, presenting that as a possible risk factor. In terms of diagnosis, typically we'll do an endoscopy with cytology and biopsy to confirm, and then staging will be done with CT or PET scan. Staging, again, very similar setup to what we see with other cancer types. So stage 0, it just means you have increased risk factors for developing this type of cancer. Stages 1 and 2 are more mild forms. So with stage 1, the lesions don't penetrate the full thickness of the esophagus, but in stage 2, they do. And then stage 3, you have some lymph node involvement. And stage 4, of course, you've got some distant metastasis. So some other notes here. So we've identified pretty much the main ways to prevent this type of cancer, which makes it a little bit more confusing as to why rates of adenocarcinoma continue to rise. Some think that older adults who end up with this type of cancer just don't report their symptoms. And there was a push for screening, since we do know a lot of the risk factors, but evidence has not shown any change in the ability to reduce rates of morbidity and mortality. And so it may help high risk people, just to have that surveillance, but for others, maybe not so much. And then, GERD and Barrett esophagus has been identified as a major risk factor and contributing factor, but 40% of individuals with esophageal cancer have no history of GERD symptoms. So just worth noting that as well. So it's not not as cut and dry as it may come off to be. So for treatment and prognosis, stages 1 and 2, they're able to go in and surgically remove that tumor because it is still localized. And surgery is only preferred in those early stage patients. And typically afterwards, they will use chemoradiation as well in order to prevent recurrence, which is fairly common, like with most types of cancer. But when that distant metastasis occurs, stages 3 and 4, it's a much, much poorer prognosis. They're not usually able to go in and remove or treat at that point. You will see medications used. So you can see some inhibition of growth factor receptors there. And 30% of esophageal tumors overexpress that HER2 growth factor receptor, but that can only improve mortality by a few months. So it's kind of delaying the inevitable, unfortunately. The prognosis is poor overall because this type of cancer metastasizes very quickly. But of course, the survival rate does depend. So you can see even for stages 1 and 2, which is the good stage in this case, where they are able to go in and surgically remove, it's only a 43% 5-year survival rate. Again, recurrence is fairly common here. And then you can see the survival rate decreases dramatically. That stage 4, only 5% survive within 5 years. And part of that is because it is extremely difficult to remove lymphatic vessels in those areas once they have been impacted. And so it's very, very difficult, very poor prognosis. So PT implications, going back to our GI red flag questions. Are you having difficulty swallowing? Any issues with indigestion? That sort of a thing. And then your typical GI cancer precautions, limiting your alcohol intake, try to stop smoking, healthy diet. Chemotherapy-induced bone marrow suppression. So we've talked about that in previous units, but typically if a patient, if they're post-op, if they had stage 1 or stage 2 esophageal cancer and they were able to go and have that removed. So looking for things like issues with clotting, anemia, that sort of a thing. So being aware for those, that's a big one. Incorporating aerobic exercise into the treatment plan. So moderate aerobic exercise, again, a lot of similar things that we would see with any cancer patient. Then some other ones here, airway clearance techniques for patients post-surgery if they were stage 1 and 2. And then patient education for risk factors, just making people aware if it's suspected that they are on that track. So again, going back to Black men are at a higher risk for squamous cell carcinoma, and then middle-aged white men for adenocarcinoma. And so I included this article. I just threw a link in there. So it's from the New York Times a couple years ago. And the man in the picture, he was one of the first to receive a new type of pharmaceutical treatment that's been tried. It was used in the past, to treat other forms of cancer like Hodgkin's lymphoma. And they said, hey, let's try and see what the effects are with esophageal cancer. And they gave it a shot. And it's actually shown some promise to help treat some of the symptoms. And so it's a little early to be able to tell what the long-term impact will be on prognosis. But again, just a good read if you're interested. So this is a very deadly form of cancer. And so we're trying to find any way we can to improve quality of life and improve the prognosis.
All right, so the next section that we're going to go over is hiatal hernias. So just an overview. So this occurs when the esophageal hiatus, which is actually located in the diaphragm, becomes enlarged. And because of that enlargement, the stomach will actually pass through the diaphragm. It can be congenital or acquired. So congenital would be when there's a failure to fuse those developmental parts of the diaphragm. And acquired would be examples of sliding or paraesophageal hernias, and we'll go over those here. So here's just like kind of a picture of what a hiatal hernia is. And so as you can see in the normal on the left, everything seems to be in order. There's no rupture, or the stomach isn't passing through this little gap at all. Whereas you look on the right, the picture, the stomach is passing through that gap and opening up into the diaphragm. So sliding hernias are when the hiatal tunnel surrounding the esophagus is widened or lax. So the muscles there are a little relaxed. The phrenoesophageal membrane is important in anchoring the esophagus to the diaphragm, so making sure that the esophagus isn't going to be sliding around, hence the name. When swallowing, contraction of the muscles in the esophagus will contract, which actually shortens the esophagus and will stretch that phrenoesophageal membrane, which allows the esophagus to go back into place after swallowing, so it doesn't just stay contracted the entire time. As time goes on, the wearing happens on that membrane, which will decrease the ability for the membrane to recoil the esophagus and allowing that esophagus to come back into its rightful place. Laxity of the membrane can result from acid reflux, straining, vomiting, increased pressure in the abdomen, widening of the musculature. So just anything that's going to cause it to wear down and to not allow for the esophagus to return back to its place. And laxity of the gastroesophageal junction will allow it to go above the diaphragm. But however, the fundus of the stomach will still remain below the junction. It'll just come up a little bit. Paraesophageal hernias, so this was the second one, they are developed secondary due to surgery or trauma. So this will cause the laxity of the gastrophrenic and gastrocolic ligaments, which are in charge of holding the stomach in its rightful place. So it's important in keeping that stomach down instead of allowing to come up, kind of what we saw in that picture. Without these, or with the laxity in these, the stomach will allow, or it will allow the stomach to come through that membrane. And that membrane is just above the junction. So if it's going through the membrane, it's also going through that junction as well. So these hernias are considered a true hernia, and a hernia is considered true if the organ protrudes through the normal aperture. So if the stomach hadn't gone through that membrane, it wouldn't be considered a true hernia, even though it is a hernia. But because these allow the stomach to actually go completely through the hernia or allow a part of the stomach to go through the hernia, then that is why it is considered a true hernia. And sometimes this defect can be large enough to allow other organs in, such as like the colon, the spleen, or the small intestine. And so it doesn't always just mean the stomach is going to be involved. And so again, if it's large enough, then some of these other organs can be involved. And again, that's just going to cause a whole lot of issues. So on the left, you can see just the normal picture. So again, stomach is below that membrane and that junction. It's not impeding into the diaphragm or the esophagus at all. You have your sliding hernia. It's not protruding out at all. It's still staying within, but it is protruding more up instead of out, up into that esophagus diaphragm area. Whereas the paraesophageal is completely breaking through the diaphragm and the membrane and junction. So it's just kind of out in space. So hiatal hernias can be symptomatic or asymptomatic. It just kind of depends on the person. It happens more in women, and it's actually pretty common. Children, they may have sliding hernias, but if they do, it usually symptoms don't show up until about middle age. And it also will increase, the incidence will increase with age. It can be as high as 60% in people older than 60 years old. Etiology and risk factors. So the weakening of that diaphragm muscle, which causes that laxity and allows that protrusion of the stomach, or it'll alter the hiatus and increases the intra-abdominal pressure. So the hiatus is an opening in the diaphragm, which allows for the passage of the esophagus. So that altering of the hiatus, once again, will allow more of that protrusion of the stomach to happen. So muscle weakness can be caused by surgery, it can be congenital, it can be trauma, or just aging. Clinical manifestations. So the most common symptom is heartburn or reflux. Incompetence, allows for that acid to enter into the esophagus, which may help cause that laxity. So it may reflux, which doesn't allow the acid to return into the stomach due to pinching of the diaphragmatic musculature. Symptoms are dependent on the type of hernia. So if someone is wearing tight clothing or someone's in a side-lying position, that may cause more problems for them. The sliding hernias may cause heartburn after a meal, so about 30 to 60 minutes. And then it can also cause dysphagia, shortness of breath, and even large sliding hernias with reflux may be associated with substernal pain. Diagnosis, there's 3 different ones. There's an endoscopy, there's a barium swallow, and an esophageal manometry. The barium swallow may be a little more sensitive to the other 2, so that's just kind of dependent on your patient, which one you think would be best. And super small hernias, or super small sliding hernias, which are about like less than 2 centimeters or so, you can't really use the endoscopy or the barium swallow to or as a diagnosis test, just because they are so small. And so the esophageal manometry is usually the best option in that. Treatment is just symptomatic control using proton pump inhibitors. And really just because a lot of this, a lot of what you're going to get is what you see in GERDs. You use a lot of the same treatments as you did in GERDs, as Delaney went over. Prognosis is pretty good overall. If the reflux and the GERDs aren't really resolved, you can go and do surgery as well. PT implications. So contraindications is lying supine in the Valsalva maneuver just because it is going to help cause that reflux a lot more readily. Patient education about avoiding activities that may cause an increase in that intra-abdominal pressure, and just teaching them proper lifting techniques, because if say they do decide to use the Valsalva maneuver as they're lifting up something heavy, that pressure increases and then it's just not good overall. During post-surgery, if they do go the surgery route, the client may have a lot of chest tubes, which is something that you're going to have to look out for whenever you're moving them around or doing exercises with them, and just making sure you're carefully observing them throughout any of the activities. And that's it.
Section 5 is gastric cancer. Gastric adenocarcinoma. It's a malignant neoplasm that arises from the gastric mucosa. It is more than 90% of the malignant tumors of the stomach. Incidence. It's the 5th most common cancer and 3rd most common cause of cancer death worldwide. Most are diagnosed in developing countries. It affects men more than women. Incidence is higher in non-whites than whites. 6 in 10 people diagnosed with gastric cancer are older than 65 years old. And there are several genetic syndromes that contribute to the development of gastric cancer. Individuals with the germline mutation in the gene E-cadherin have an 80% risk of developing gastric cancer in their lifetime. E-cadherin is a protein found within the membrane that surrounds epithelial cells. It is also a tumor suppressor and can be downregulated in gastric cancer. Classification is based on anatomic location, cardia or non-cardia. So cardia is the top of the stomach and non-cardia is the main area of the stomach. And there are 2 histological subtypes, intestinal and diffuse. Intestinal type is related to environmental and dietary factors, and the diffuse type is more so in younger people and women. Etiology. We have the Helicobacter pylori infection, which is associated with intestinal type of gastric cancer. The infection increases the risk of gastric cancer and causes chronic inflammation by inducing a host inflammatory response within the gastric mucosa and causing DNA damage and alterations to the genetic controls of normal cell proliferation. Epstein-Barr virus may also cause gastric cancer as well. The risk factors, we have low intake of fruits and veggies, salt intake and salt-preserved foods, consuming smoked fish, meat containing nitrates, smoking, obesity, chronic atrophic gastritis. And this is chronic inflammation and thinning of your stomach, which is accompanied by a change in your stomach lining cells to mimic intestinal cells. Next, we have intestinal metaplasia. This is a transformation of the cells in the lining of your upper digestive tract, often in the stomach. Next, we have pernicious anemia. This is a decrease in red blood cells that occurs when the intestines cannot properly absorb vitamin B12. And the last 2 are previous gastric resection and gastric adenomas. Pathogenesis. This is a multi-step process. It requires years with changes in genetics and epigenetics, DNA modifications. It leads to dysregulation of the cell. H. pylori and Epstein-Barr virus use epigenetic mechanisms to alter gene expression. H. pylori quiets tumor suppressor genes and deregulates cell pathways. The Epstein-Barr virus displays distinctive hypermethylation pattern. DNA changes lead to acute and chronic gastritis, developing into atrophic gastritis, intestinal metaplasia, dysplasia, and gastric carcinoma. Clinical manifestations, so the two most common ones are weight loss and abdominal pain. Other symptoms may include early satiety, nausea, vomiting, gastric outlet obstruction, which is tumors near the pyloric sphincter, and occult bleeding. Most people, around 80%, remain asymptomatic until the disease is advanced, which leads to a poor prognosis. 50% of people are candidates for surgical resection and cure. 5% of peptic ulcers possess gastric cancer. For prevention, for medical management, we have screening, endoscopy for individuals with a genetic risk factor, surveillance endoscopy for individuals with an endometritis, gastric polyps 1 year after removal, and then every 3 to 5 years. Diagnosis and staging. So the diagnosis may be delayed due to a lack of symptoms and symptomatic relief from non-prescription medications. First test performed is an endoscopy with biopsies of suspicious lesions, and the tests used to stage gastric cancer are CT, endoscopic ultrasonography, and laparoscopy. So an endoscopy is a visual and biopsy of the gastric mucosa that can detect early gastric cancer. On the top right, we have a CT. This is used in gastric cancer tumor staging. It can demonstrate the size and location of the cancer, wall thickness, and the spread of the tumor. And the bottom picture is an endoscopic view of an ulcerating endocarcinoma. With an endoscopic ultrasonography, it can delineate the depth of tumor invasion through the layers of the gastric wall and lymph node involvement. In a laparoscopy, on the bottom right-hand corner there, it's used to see if the cancer has spread. For the stages, we have stage 1. This confines the tumor to the stomach into 1 or 2 nodes, and it's only in 10% of people with gastric cancer. Stage 2 confines tumor to the stomach in 3 or 6 nodes. Stage 3, the tumor has grown through the stomach wall and spread in up to 16 nodes. Stage 4, it's gone to other surrounding organs. And stage 4 is where 2/3 of people are with gastric cancer. Continuing on with medical management for treatment, the stages of 1, 2, and 3, most likely surgical therapy is the treatment of choice, but other options include chemotherapy and radiation. Individuals who are not candidates for surgery may go through palliative chemotherapy and stent placement for obstruction of the pylorus, but the disease is incurable. HER2 growth factor receptor can be overexpressed and is treated using the anti-HER2 monoclonal antibody, and this is called trastuzumab. And lastly, all metastatic gastric carcinoma should be evaluated for the presence of HER2. For prognosis, it depends. It depends on the extent of gastric wall penetration, lymph node involvement, and location site. The 5-year survival rate is 31% as a result of late-stage detection. PT implications: epigastric or back pain, which can be relieved by antacids, We want to change positions every 2 hours after surgery. And to prevent pulmonary complications, we can include deep breathing, coughing, incentive spirometry. In the semi-Fowler position, which assists with breathing and drainage following a gastrectomy.
Alrighty, now we are going to go ahead and talk about peptic ulcers. So the peptic ulcer definition is a break in the lining of the stomach or the duodenum of 5 millimeters or more, owing to a number of different causes, which I will get into in a later slide. There are two different types of ulcers. There's the gastric ulcer and the duodenal ulcer. There's also stress ulcers that occur in response to significant psychological stress. In the bottom corner of the picture, it shows what these ulcers could look like and where they could be. So the one that's in the stomach right here, I don't know if you can see that, but it's in the stomach, and that's your gastric ulcer. And then the one that's down over here on the bottom corner, closer to where all the words are, is your duodenal ulcer. Incidence, so this affects approximately 6 million people per year in the US. The prevalence rate is 3.3 and the lifelong prevalence is 13.8, and there's a whole bunch of cases diagnosed each year. So in these two pictures, the one in the top left corner, it shows a normal stomach ulcer or a normal stomach. There's no ulcers there at all, looks good. And then the part on the right where it does show the stomach with an ulcer, that is going to be your gastric ulcer. There's no duodenal ulcer present. In the bottom corner of the other picture, you have the healthy stomach, and then you have your gastric ulcers as well. But this one also shows the duodenal ulcer and where that would be. So for a peptic ulcer, the etiology, there's a whole bunch of causes, but the most common cause are NSAID use, low-dose aspirin, and H. pylori bacterial infection. H. pylori is normal in the stomach. It just happens to get infected, and then that can cause an ulcer. There's a whole bunch of risk factors: cancer, psychological stress, diet, caffeine, alcohol use, tobacco use. So the pathogenesis for a peptic ulcer is an imbalance between mucosal insults and mucosal defenses. So some defenses can include mucus, bicarbonate layer, and prostaglandins. There are a whole bunch of insults, but some of the insults that include are acid, pepsin, alcohol, biosalts, drugs. Again, the most common factors that cause this imbalance can lead to an ulcer is an NSAID use in the H. pylori infection. So gastric acid gets inhibited by somatostatin and prostaglandins, and a prostaglandin deficiency can lead to ulcer formation. An H. pylori infection causes an inflammatory response in the gastric mucosa that attract neutrophils and macrophages to that area and then break down that mucosal barrier. So some clinical manifestations, if you study this slide, you'll be good. Classic symptoms with PUD that are present include epigastric pain described as burning, gnawing, cramping near the xiphoid process that can radiate into the back. They also have been able to see that pain may be relieved with eating and can occur at night. Some nonspecific symptoms include nausea, abdominal fullness. So the pain in the xiphoid process will be like right in the front of your stomach, and then it can radiate to the back as well. So referred pain patterns are present. Red flag symptoms that are worrisome for malignancy are unintentional weight loss, iron deficiency, bleeding, persistent vomiting, jaundice, and those are some red flags for like gastric cancers. Again, that picture just kind of shows some common symptoms with the two ulcers there as well. Some complications for this include bleeding. So you have acute and chronic, and this is the most common complication requiring hospitalization. And then you have perforation, which is a sudden severe pain between T6 to T10, and then bowel sounds will be absent. And then penetration is when the ulcer erodes into adjacent organs, so the small bowel, pancreas, or liver. Pancreatitis is the most common presentation. And then this one's rare, but gastric outlet obstruction can occur because of scarring in the prepyloric region from healed ulceration. So they had ulcers in the past, and then they healed, and then something happens, and then there's more scarring that comes up. In the picture, again, it just kind of shows what those could be. It kind of shows the two major ones, bleeding and perforation. Yeah. So medical management. Diagnosis, you can do a double contrast barium studies, which is in the upper GI tract and is less expensive. There's an antibody testing for H. pylori. Any individual with a peptic ulcer or ulcer should be tested for this, just to rule out that it is not the H. pylori, and if it is, it can get treated. There's an upper endoscopy, oh my gosh. This is the test of choice. This can determine the site of the ulcer, but it can also get biopsy specimens if they believe that there could be cancer. Treatment, this depends on the cause of the ulcer. So if they're taking an NSAID, you want them to stop taking them. H. pylori, if that is present, you must get rid of that organism. But most treatments are 70 to 90% effective. Then you have prevention. So you want some lifestyle changes. You want them to stop smoking. You want to limit alcohol, and you want to take some probiotics. You can get probiotics at any store. Walmart sells them, Kroger sells them. Just go to the pharmacy area. Prognosis is usually good. It has improved due to improved medical treatment. However, in elderly, the mortality rate of a perforated ulcer is 3 to 5 times higher. And then mortality from bleeding ulcers is approximately 5% increase in elderly. So some PT implications, you want to monitor vital signs, common with across almost all pathologies. You're going to want to monitor signs and symptoms. So you want to observe their color, activity level, or exercise tolerance, and then their fatigue level. And then I talked about referred pain patterns. So ulcer pain can occasionally radiate to the mid-thoracic back or the right upper quadrant. So just keep an eye on for that. And then exercise. Exercise has been proven that it can reduce bleeding greatly if you do it at least 3 times a week. So just get that exercise in and you'll be good.
All right, and last little section here, we're just going to touch on these two, the esophageal atresia and tracheoesophageal fistula. So they are the most common esophageal anomalies. They're very common, with 1 in 4,000 people having it, and very equal gender distribution. So esophageal atresia is when the development of the esophagus fails to be a continuous passage. Whereas the tracheoesophageal fistula is when there's abnormal communication between that trachea and the lower portion of the esophagus. And so there's a lung bud that fails to separate completely. The etiology is the cause is unknown, and this is very prevalent in babies and children. Clinical manifestations. So for children, there's going to be a lot of drooling and possibly aspiration, just because they can't. A lot of that can't be swallowed, and so it will overflow the pharynx, and ultimately it can't go anywhere but up at that point. So there's going to be a lot of drooling at that point. So there's kind of a triad of what to look for these, and it is coughing, choking, and cyanosis, because if they aren't able to dispel all that fluid, then it's going to be really difficult for them to breathe. So here's just like a couple pictures of atresia and fistula. So as you can see here on the very top left, here's kind of what normal looks like. The trachea and the esophagus are completely separate from each other, and the esophagus goes straight down to the stomach. If you see the atresia with the distal fistula kind of in that middle there, the fistula causes the esophagus to connect with that trachea, which, as we all know, that's not good at all, because your trachea is what helps you breathe. And so the If you look up to the top right, the atresia with the fistula, that means the esophagus on both the top and the bottom there is connecting to that trachea. And here's some more pictures on the right side here of kind of what that looks like. So there is that disconnect of the esophagus with the stomach, which can cause a lot of problems. And as you can see, why there is a lot of drooling that happens in children with this. So diagnosis, since it occurs with babies, it's going to be at birth, and kind of looking at some of those clinical manifestations. So that drooling, that cyanosis, that coughing, things like that. With newer technology, it is more possible and more readily available to do it in utero, just to be able to catch it early. And you can do it with a esophagography or a bronchoscopy. Treatment is going to be surgery, just to help with that connection, to help make sure that esophagus is completely continual instead of being broken up. And then also just eliminating the fistula so that it's no longer connected to the trachea. Prognosis, without early diagnosis or treatment, it's pretty fatal, just because it is harder for the child to breathe. But if you can get the surgery and you can get that early diagnosis, then the long-term survival rate is 90%. So prognosis is pretty good. So here are our references. And yeah, well, thank you so much for listening to us, and have a great rest of your night.